Leong, who's going to speak with us about the future of oncology and aging, and I'll hand it over.
Thanks so much, Ted. So my emphasis is going to be more on the future side of things rather than necessarily on the technology side of things. So you saw these data yesterday presented by Sir Richard, and what they demonstrate to us is that globally populations are aging, whether you look at it overall, whether you look at it stratified by country income level or stratified by age. Overall populations are aging. Now the corollary of that is, well, the corollary of reduced deaths is that we're seeing older and older populations. And I think folks in the room will understand the reasons why. These are the top 10 causes of death in the US in 1900 as opposed to 2010. And what you'll observe is that the bottom three cells in the 1900 column, that is GI infections, tuberculosis, and respiratory infections, have largely vanished in the US. And that is why their mortality rates have halved over the last century. So firstly, we observe a transition from communicable disease, or away from communicable diseases, more to non-communicable diseases. However, even within non-communicable diseases, we have also observed epidemiologic transitions. So this demonstrates cardiovascular mortality rates over the last 60 years in a number of high-income countries, showing progressive declines in all of these countries over that time. And I don't want to de-emphasize Sir Richard's point about perhaps this trend tailing off, but for the purposes of this talk and argument, I'm going to adopt the optimistic position that reductions in cardiovascular mortality will continue. And so with this in mind, I pose the question, what are the sequelae of reducing infection-related and cardiovascular mortality rates, and thus aging populations going to be globally? And the two areas that I would put forward as being important consequences of these reductions are cancer and frailty and multimorbidity, and I think these are very important health challenges. Now, I won't speak to cancer in a great deal of detail other than from a brief epidemiologic perspective. Cancer as a clinical research subject will be explored in more detail tomorrow with Dr. Levine at the think tank. But cancer is certainly, or to a large extent anyway, a disease of aging. What you see here in the US is that the incidence of cancer, of many different types of cancers, increases with age. Interestingly, it does seem to plateau at about the age of 80, and I'm not entirely sure the reasons for this, but by and large, most cancers are diseases of aging, and there are good biologic reasons why this is so. Here are our observations from the PURE study with which you're all familiar. This looks at the causes of death in low, middle, and high-income countries in PURE, and these were presented at the ESC. If we look at low-income countries on the left-hand side, you'll see that 43% of deaths, the largest proportion, were due to cardiovascular disease, and that injuries, cancer, respiratory diseases, and infections roughly accounted for similar proportions in terms of causes of death. When we then move to the middle-income countries, we see that injuries, infection, and other causes of death shrink as proportions of all mortality. Cardiovascular disease remains similar at about 42% of all deaths, but cancer increases to account for about 30% of all deaths. And then when we move to high-income countries, the pattern is more exaggerated, where infectious diseases, injury-related deaths are an even smaller proportion, whereas cancer mortality increases substantially as cardiovascular mortality reduces to account for less than a quarter of all deaths in the PURE experience in the high-income countries there. So I think these data tell us that even today in high-income countries, cancer is a very important health outcome, and if patterns in middle and low-income countries follow suit, which I think that they're likely to do in due course, cancer is likely to become a very important cause of death in those settings as well. And therefore, we can actually expect cancer to be a leading cause of death, if not the leading cause of death globally, perhaps in a few short decades. What I would like to spend more of the slides on is to discuss frailty and multimorbidity in a little more detail. So what is frailty? It has been defined, I think, reasonably well as a state of reduced physiologic reserve which can lead to a vulnerability to a poor outcome such as death when confronted by a physiologic stressor. But how does that, that definition translate into a characterization, into something that we can measure? Typically, frailty has been measured in the literature by a combination of physical characteristics, and some of these are listed here, such as muscle strength, gait speed, physical activity levels, and subjective feelings of exhaustion or unintentional weight loss. Frailty is related to biologic aging, and indeed is also related to multimorbidity, which is the presence of 2 or more chronic diseases, but the 3 are not synonymous. And as a simple thought experiment, one can often, I think, picture an elderly person who is quite robust and does not have any known illnesses. And similarly, in the hospital, we frequently see younger individuals with multiple health conditions who are very frail. And so while these 3 phenomena are not necessarily the same, it has to be recognized that they are related to each other. We believe that frailty is important for this reason. These are data in PURE that are under review at present, looking at the estimated number of life years lost per participant over 10 years follow-up. And the different colored bars represent hypertension in the blue, diabetes and smoking in the 2 green colors, and frailty in the purple color. And we see the data presented both overall and disaggregated by age strata. What we observe is that frailty at all age strata contributes, we believe, or is associated with, at the very least, more life years lost than other risk factors which we would regard as crucially important. And I think this underscores why we feel frailty is a very important phenomenon to study. How is it that frailty does lead to loss of life, and what is the process that's involved? Again, these are data from PURE looking at deaths following an incident disease. So the various incident diseases during follow-up in PURE are listed on the horizontal axis, and case fatality rates are presented on the vertical axis. And you'll see the bars representing different levels of muscle strength, where blue is low muscle strength, red is middle third of muscle strength, and green are the strongest individuals. And I guess it won't come as a huge surprise, but there is a very strong relationship between having low muscle strength and having a high likelihood of succumbing to an illness, no matter what type of illness it is, should you get it. So while this is not surprising, what did surprise us a little bit in PURE was this analysis. We looked at the risk of death in individuals with no known past history of any chronic disease, and who also did not develop any chronic disease during follow-up. And you see that the mortality rates in the frail are in the bottom dashed curve, and in the most robust individuals, the solid blue curve, and those who are pre-frail or intermediate in the red curve in between. What we observe is that there is about a 3-fold higher risk of death in the absence of any clear disease in those who are frail. And while we acknowledge that this analysis has limitations and has some potential flaws, it does raise the hypothesis that perhaps frailty is an avenue to death that is independent or unrelated to disease. And I think that will be consistent with the slide I showed previously. And therefore, if we can address frailty successfully, it may allow us to improve health outcomes in a completely new way and with a completely new paradigm. Multimorbidity, the presence of 2 or more chronic diseases, also poses some unique challenges. One such challenge is clinical decision-making in the context of competing risks. And one that I thought I'd mention in particular was the appropriateness of extrapolating evidence that is derived from populations that are predominantly single disease populations to a population with significant multimorbidity and perhaps also frailty. And just to illustrate the point, I thought we could describe a simple thought experiment. Consider a 75-year-old man who has a non-STEMI, modest elevation troponin, now pain-free and comfortable, and is found to have triple vessel disease at cardiac catheterization. Who here would put this individual forward for coronary artery bypass surgery? Perhaps I could have a show of hands. Hopefully there are many people who would agree that this is a strong indication for coronary bypass surgery. But then if the same question is posed about a 75-year-old man who also happens to have metastatic small cell lung cancer with brain metastases, I think there would be even fewer hands in the room raised. And I think this is fairly intuitive, that the competing risk is likely to claim that individual's life before the coronary artery diseases. But how about if the individual had stage 2 non-small cell lung cancer, which is potentially treatable, especially in the context of newer therapies which are proving more and more effective? And so you see that the waters become muddy, and it becomes difficult to necessarily extrapolate some of the evidence which forms the basis for our guidelines to these sorts of complex conditions and complex circumstances. Also, I think multimorbidity gives us new patterns of treatment-related adverse effects that we need to consider. And so for the last few slides of my presentation, I'll just pick on one particular disease, and I could have picked on a number of other different malignancies with which I sort of deal clinically. But we'll take chronic lymphocytic leukemia as an example, because this is actually the most common leukemia in Western countries. In many individuals, it is asymptomatic, and the outlook is a long one. It's a favorable one. However, when CLL becomes symptomatic, survival progressively deteriorates, and ultimately it can be a fatal disease. Until recently, there were relatively few very effective treatment options. However, the development of targeted cancer therapies has led to the identification of a receptor pathway mediated by Bruton's tyrosine kinase that was thought to be very important in the pathogenesis of CLL. And so this drug, ibrutinib, was developed, which is a BTK inhibitor. And what you can see is that ibrutinib reduces the risk of mortality, so overall mortality, as well as disease progression, by a whopping 80%. So a relative risk that we just won't see in cardiovascular disease anymore, I would think. So a profoundly effective drug. It does have off-target side effects. We observed that it seemed to be associated with a high risk of atrial fibrillation. And in fact, this is a meta-analysis of randomized trials comparing ibrutinib with some form of comparator, showing consistently about a 4-fold increase in the risk of atrial fibrillation in those who were treated with ibrutinib. Now, that said, I don't think anyone would suggest necessarily stopping a clearly life-prolonging drug because one develops atrial fibrillation as a result of it. But there are other complexities. For instance, ibrutinib increases the concentration of diltiazem, verapamil, and amiodarone, so drugs that we commonly use to treat atrial fibrillation. And thus, the management becomes a little more challenging. What is even more challenging is we also observe that ibrutinib increases the risk of bleeding. So shown here are the incidence rates of overall bleeding and major bleeding in a systematic review when one is exposed to ibrutinib as opposed to, in some randomized trials, a control group. And we see bleeding rates and major bleeding rates with the use of ibrutinib that approach those of perhaps anticoagulation. So the point was not so much to belabor chronic lymphocytic leukemia therapy, but rather to make the point that established therapies really need, I think, re-evaluation in the context of multimorbidity and of frailty, because it may not be appropriate to extrapolate what we think we know to these newer populations of individuals. So lastly, what are we currently doing at PHRI to try and address some of these challenges in frailty and multimorbidity? I think the first step to developing effective interventions to either prevent or reverse frailty is to understand how it develops in the first place. And we're very fortunate that we have a number of large cohorts in which frailty has been measured at baseline and is being or will be measured during follow-up. We obviously have data from the PURE study, which will be an extremely valuable resource in the general population. We also have we will have, we hope, 4,000 individuals in the GCHF heart failure study, in fact, in a sub-study of the GCHF study, in whom frailty has been measured at baseline and will be measured during follow-up as well. And we also have a fairly large Canadian cohort of prostate cancer patients currently standing at 2,500, and we hope to increase this number, ideally with international collaboration, to 6,000. And so we hope to leverage these cohorts to understand in healthy individuals, as well as those with an established disease, what processes and what exposures lead to the development of frailty. We also, I think, need to develop expertise and evidence to guide us in the management of patients with complex multimorbidity. And the example or the thought experiment I provided before really speaks to the fact that randomized trials may not have been geared to dealing with these complex patients or addressing the question in complex patient populations. And I put it to you that I think randomized trials should really ideally be pre-specified to have either analyses and or stratification done by levels of multimorbidity and frailty to understand if the risks and benefits that we see in the overall population are true in the frail or the multimorbid. I think as an acknowledgement of the relevance of multimorbidity, many of you will be familiar with this new specialty called cardio-oncology. And so as the name suggests, this is really the management and the prevention of disease, of cardiovascular disease in individuals with active cancers. And so by definition is a specialty that caters to the management of multimorbidity. I think that the paradigm of cardio-oncology needs to be expanded to really include multidisciplinary survivorship clinics that understand the individual as a whole person and not just as a disease entity. And so really to finish my presentation, this is a collage, I think, of images related to cardio-oncology, just to prove that this is not something that's a pipe dream. This is reality. So we see that at the American Heart Association last week, this was a featured session of the American Heart Association sessions, and they've committed $15 million to this field of cardio-oncology. Next year, the 5th, I think, annual Global Cardio-Oncology Summit will be held at Toronto, which will be an exciting event here. And we were very proud that our work was the first paper published in the inaugural Jack Family Journal devoted to cardio-oncology. So to conclude, I feel that cancer, frailty, and multimorbidity are growing aging-related health challenges that we need to be able to confront. And to do that, we need further research to understand what causes these conditions to develop, and we need more research to develop strategies to address them. Thank you very much.